Hello, everyone. Welcome to the NHRC site presentations, and thank you for joining us today. I just want to make a quick announcement that as part of our education subcommittee, we've decided to change slightly the way we do things a little bit for this coming academic year. And so we're going to have various members of our subcommittee moderating the sessions each month. So in the past, it was our co-chairs moderating. And I just want to also give a great shout out to Daniel Ibarra Rios, who was a fabulous co-chair for this committee and really set a high bar for the rest of us to follow. I'm gonna turn it over now to our other committee members, Mahmoud Montasser and Irina Prelipcean, who are gonna moderate for us today.
Thank you, Tina. Welcome again, everyone, to today's session on precision in the care of infants with HIE as part of the NHRC site presentation series. I'm honored to be one of the moderators for this insightful discussion. So today we have the privilege of hearing from Dr. Marjorie Makoni and Dr. Chatmethakul. Apologies if I butchered your name. Pearl is an assistant professor at Oklahoma Children's Hospital, and Marjorie is an associate professor at the same hospital. And they lead this innovative TNECO hemodynamics program there, and their expertise will undoubtedly reach our understanding of today's topic. So following their presentation, we'll, of course, open the floor for an interactive discussion. I'm sure it will be quite interesting discussion. Where we'll start. The moderators will pose a couple of questions to our speakers, and then of course, please feel free to actually participate and ask questions directly or place them in the Q&A box. Joining our speakers on the panel today, we have three distinguished experts. Dr. Khorshid Mohammad, he's a pioneer in neonatal neurocritical care and a clinical professor of pediatrics at the University of Calgary. We have Dr. P.I. Wintermark, a leader in neonatal neuroscience and founder of the NeoBrain Lab for Montreal Children's Hospital and McGill University. And Dr. Phil Levy, who's advancing pediatric ultrasound research and quantitative cardiac phenotyping at Boston Children's Hospital, Harvard Medical School. So together, you see, we have an amazing and diverse expertise and research interest and profound insights that will hopefully guide our exploration into this new frontiers in the neonatal neurocritical care. So thank you again for joining us today, and I'm looking forward to a very stimulating exchange of knowledge.
Thank you so much, Irina, for your kind introduction. And thank you so much for having me and Marjorie here. Over the next hour or so, we'll be talking about perinatal hypoxia ischemia events and how integration of physiology and neonatal hemodynamics knowledge can be helpful in clinical situations. We have no conflict of interest to disclose. For today's presentation, I will start with an overview of physiology associated with perinatal hypoxia and ischemia, starting with fetal adaptation, postnatal compensatory mechanisms, as well as the effect of cooling and rewarming. Marjorie will then take over to present the cases that we have here at our institution. The fetal brain is relatively protected from asphyxia as compared to humans at any other phase of life. This is multifactorial and in part related to fetal and placental compensatory mechanisms and fetal circulatory adaptation. Interruption or critical reduction in fetal blood flow precipitates centralization of blood flow to the heart, brain, and adrenal glands. To facilitate this, the hypoxia actually triggers a surge in catecholamines, producing vasoconstriction in organ bed. Mild to moderate fetal hypoxia leads to peripheral, renal, splanchnic, and pulmonary vasoconstriction, diverting blood to the brain, heart, and adrenals. This can be done through increase in pulmonary arterial pressure, which lead to increased right to left shunt at the foramen ovale and increases blood flow in the ascending aorta, thereby enhancing cerebral and coronary perfusion. However, in the severe hypoxia, it leads to reduced blood flow to brain and heart, causing neonatal encephalopathy, myocardial ischemia, right and left ventricular dysfunction, as well as pulmonary hypertension. The pathophysiology of HIE is very complex. Many factors affect the extent of damage caused by hypoxic injury. The initial insult occurs when the brain is deprived of oxygen, with the ischemic event influences the integrity of pre-existing neuronal cell types in the brain. This initial insult happens within minutes, making this extremely brief and difficult period to target using medical therapy. Following the initial insult is a latency or reperfusion period. During this period, cerebral autoregulation is disrupted. Severe disruption of autoregulation resulted in pressure-passive cerebral circulation, which resulted in increased risk of reperfusion injury. During this time, cell damage is actually mediated by pro-inflammatory signals, an imbalance of excitatory and inhibitory neurotransmitter release, and oxidative stress, which in combination led to eventual cell necrosis and apoptosis. In clinical practice, however, the exact timing of injury is frequently unknown. Current guidelines for initiation of therapeutic hypothermia are based on evidence from animal experimental models where the insult was timed, suggesting the secondary failure after 6 to 15 hours. It is believed that hypothermia may modify cell program for apoptosis, leading to their survival, thus considered to be neuroprotective. The neonatal cardiomyocyte is particularly vulnerable to the effect of asphyxia. And as we know that interaction between cardiovascular system and central nervous system injury can potentially affect the outcome, I would like to next focus on the cardiopulmonary effect of perinatal asphyxia. Multiple clinical studies have validated the frequent presence of myocardial ischemia among neonates with perinatal asphyxia. And as echocardiography techniques has become more sophisticated, a more robust literature describing the specifics of cardiac dysfunction has evolved. Markers of left ventricular systolic function lower than expected for age has been reported using tissue Doppler imaging and speckle tracking to evaluate myocardial velocity and deformation, respectively. This graph shows that peak systolic strain and strain rate were lower in the asphyxiated neonates than that in the control group. This next graph shows that peak systolic strain was lower in the asphyxiated neonates than in the control group during the first 3 days of life. Moreover, extensive studies by Regan Giesinger also show an association between abnormal RV function at 24 hours of life and abnormal brain magnetic resonance imaging. So as we can see here, both ventricles are affected as a result of perinatal asphyxia. Moreover, in infants with perinatal hypoxic ischemic events, cardiac output declines over time, sometimes rapidly as the RV become increasingly unable to pump against high afterload, and hypoxia will eventually occur due to critical organ underperfusion. This diagram here actually shows multiple causes that can contribute to further systemic hypotension in pulmonary hypertension associated with patients with HIE. Firstly, pump failure can occur, which is often due to ventricular dysfunction from ischemia that we have discussed before. Secondly, reduced preload from reduced pulmonary venous return also play a role here. Next is a reduced afterload due to adrenal failure and the effect of medication that we are using, especially sedative and muscle relaxant. Lastly, adrenal failure, which can be secondary to bilateral adrenal hemorrhage. Management of systemic hypotension is crucial to optimize blood flow and oxygen delivery to the brain and heart, which bring us next to the topic of what happens to the pulmonary system in patients with perinatal asphyxia and how it affects the cardiovascular system. I think that to appreciate the postnatal implication of pulmonary compensatory mechanism, it is important to understand that high pulmonary arterial pressure has different manifestations depending on the adequacy of ventilation and perfusion matching. This figures illustrated ventilation perfusion changes associated with neonatal encephalopathy. First, in mild HIE without lung disease, alveolar ventilation and pulmonary arterial pressure are normal with optimal lung perfusion. However, in the setting of parenchymal lung disease, such as meconium aspiration syndrome, asymmetric lung disease leads to alveolar hypoxia and constriction of pulmonary vasculature by hypoxic pulmonary vasoconstriction. In severe HIE without lung disease, systemic vasoconstrictors can lead to impaired regional pulmonary blood flow. Impaired gas exchange then lead to alveolar hypocapnia and regional pneumoconstriction. Lastly, a combination of severe HIE and parenchymal lung disease can lead to severe elevation of pulmonary arterial pressure, causing right ventricular dysfunction. From the previous slides, we see that high pulmonary arterial pressure leads to high RV afterload, and we all know from stress velocity relationship, the neonatal heart are more susceptible to dysfunction in the setting of high afterload. Therefore, infants with HIE are more susceptible to RV dysfunction because of high pulmonary arterial pressure. Moreover, perinatal asphyxia can be associated with low systemic diastolic blood pressure that we have discussed previously. A combination of low systemic diastolic blood pressure and a high right atrial pressure actually is a bad combination, resulting in low coronary perfusion pressure and leads to further myocardial ischemia. Furthermore, reduced pulmonary venous return due to pulmonary hypertension and deviation of the interventricular septum to the left actually further results in low LV preload. These chains of events that I have discussed here actually resulted in cascade that cause cardiovascular instability. So apart from the cardiopulmonary effect of the disease itself, because we have found that therapeutic hypothermia is neuroprotective, infants with HIE typically would receive cooling as a standard of care currently. However, like all things neonatology, our treatments do come with side effects. So it is also important for us to know how cooling and rewarming affect cardiopulmonary physiology in the patient. It has been found that in HIE patients with pre-existing lung disease or hypoxemic respiratory failure tend to have an increase in oxygen requirement along with exacerbation of pulmonary hypertension with cooling. This was thought to be secondary to the fact that hypothermia may modulate pulmonary vascular resistance due to peripheral vasoconstriction, catecholamine release, and increase in blood viscosity, which is associated with low body temperature. Therefore, caution should be exercised in patients requiring high FiO2 or INO prior to cooling initiation. Rewarming, which is the second phase of cooling, also has its own unique impact on hemodynamics. Rewarming resulted in progressive vasodilation of the systemic and pulmonary vasculature, increase in preload, heart rate, cardiac output, and exaggerated response to inotropes. Although the hemodynamic impact of rewarming on the brain is still less described, observational studies have shown that most intraventricular hemorrhage occur during the rewarming period. With the knowledge of the cardiovascular effect of rewarming, cautions should be taken during rewarming period with a judicious use of inotropes and close monitoring of blood pressure to avoid excessive augmentation of blood pressure or cardiac output. With this last slide, I actually would like to use this comprehensive diagrams from Reagan's paper, which describe the complex interrelationship between contributors to ischemic injuries resulting from initial insult, therapeutic hypothermia, and reperfusion injury on rewarming. The recognition of hemodynamic changes and understanding of neonatal hemodynamics knowledge is essential to provide comprehensive assessment of the infant with HIE throughout the course of the treatments. Moreover, longitudinal assessments can also offer insights into disease progression and effects of the therapy. Next, I will hand over to Marjorie, who will go through how we can integrate this knowledge in clinical settings. Thank you.
Hi, I am preparing. It didn't go as smoothly as it did when we did a dry run. So bear with me here for 1 second while I get this prepared. Okay. Can you all see my screen and hear me?
Yeah, we can.
All right, so Pearl has done a wonderful job going over the cardiovascular physiology surrounding asphyxia, therapeutic hypothermia, and rewarming. So now I'd like to talk about these two cases that we had here at our center and how knowing this physiology was important and how we integrated neonatal hemodynamics and TN echo into their management. Okay, so here I have two babies that I will just on this slide present in parallel just to highlight the main concepts or the idea that sometimes you can have a baby or babies who have a very similar clinical presentation. So these two babies, baby A was outborn, a 39-weeker severe HIE who was undergoing therapeutic hypothermia. Unfortunately, due to ABG's with pH less than 6.7, this baby was not an ECMO candidate. So it was transferred to us, and on arrival, even though the baby was already on some medical therapies, the baby had severe hypoxemia, was hypotensive, had severe metabolic acidosis, lactic acidosis, and also respiratory acidosis. And then baby B was inborn to a poorly controlled type 2 diabetic mother via C-section through meconium. And this baby had moderate HIE undergoing therapeutic hypothermia. And also at the time of consult, this baby was already receiving some therapies, but had a very similar presentation to baby A. So you might wonder, why is it that these babies are already on all these medications, especially the inborn when we're here? So at our center, pediatric cardiology always does our first echoes to rule out congenital heart disease. And they give us enough information where the primary team can make management decisions based on that. So this is what happened, and I will walk you through these two cases. So there are fundamental differences between the cardiology echo and the targeted neonatal echo, as we have learned throughout this lecture series. There's a focus on functional aspects of the cardiovascular physiology in neonatal hemodynamics. Here, I have given you a very comprehensive list of all the parameters that we evaluate on TN echo, but I've grouped them into 5 core concepts that are important, especially if you are in a center without hemodynamics or TN echo. So this can help you refine your question to cardiology in order to help guide the management of your patients. So first and foremost, ruling out congenital heart disease, because if that is present, we redirect to the CVICU. And then, as Pearl has nicely outlined for us, evaluation of pulmonary pressures and resistance is important. Evaluation of RV performance, evaluation of LV performance, as well as evaluation of your shunts, especially in the setting of biventricular dysfunction or dysfunction of either one of the ventricles, will give you an idea of what is happening with your patient. Now, as we have also learned, these babies can also have all these physiologies happening at the same time. So it becomes even more important to figure out or to determine what is the predominant physiology, so we can focus our attention on that, treat that predominant physiology, and then do serial echoes to follow up and reassess. So this list is very comprehensive. Not all centers, pediatric cardiology will report all these parameters here, but I outlined them as the many different ones, especially when you're evaluating pulmonary pressures. Most echoes will have mention of the septal wall. So that is something that can help you figure out what's happening with your pulmonary pressures. They may have TR if it is present and quantifiable, RV-PAT, depending on which center you're at. For RV performance TAPSE, every cardiology echo they do measured. If they don't report it, this is something that you could ask. RV output and RV FAC, these are usually mostly found on the hemodynamics echo, and every echo will always report ejection fraction by Simpson's. So that will also be there, and as well as the size and some directionality of your shunts. So I will now go back to baby A and highlight to you what this baby's physiology was. So as a reminder, baby A is an outborn baby who came to us already on dobutamine, epinephrine, was on PGE, stress dose hydrocortisone, and on INO 100% in still in respiratory distress, hypotensive, severe metabolic lactic acidosis. So on assessment, this baby was about 20 hours old when we did our assessment. And our assessment, I'm going to present this starting with the RV. So this baby had normal RV function. As you can see here, the TAPSE was 9.2, which is about the mean for a term baby, and normal FAC and RVO. So TAPSE measurement is done right here. And this is the RV 3-chamber view. And you can see this is your RV here. And there's a good squeeze. And then on evaluating LV, this baby had moderate LV dysfunction. This was by Simpson's biplane of 35%, which the cutoff for LV dysfunction is around 55, depending on where you are. Some people say 60, but here we use 55. And as you can see, the quality of squeeze on this LV is not all that great. And shunt evaluation revealed this very large PDA that has bidirectional flow, as you can see the red and blue flash, as well as the PFO that was also bidirectional. So now we know that the hypoxemia occurring in this baby is because of that LV dysfunction that led to decreased LVO, poor tissue perfusion, and therefore poor oxygen saturation and hypoxemia on pulse ox. In this particular baby, the LVO is low compared to PVR because of systemic hypotension. So the RVO is now shunting right to left of the PDA, and that contributes to pulmonary blood flow. So, sorry, systemic blood flow. So you can see by this little diagram here. So this baby falls into this category where the baby had LV dysfunction and PPHN. PPHN, because this baby too also had increased pulmonary pressure, the systolic eccentricity index was around 2.3, which means there's pretty high pulmonary vascular resistance. So the goal of therapy in this patient would be to increase inotropy of the LV while maintaining a right to left duct to support systemic blood flow while we wait for the LV function to improve. If this baby had not been on any therapies, then the first line would be as prescribed here, dobutamine, PGE if the ductus is restricted, and epinephrine if needed, and our patient was already on hydrocortisone. So since this baby came with some therapies already, our goal was to improve LV contractility. And to achieve this, we corrected metabolic acidosis. We continued the dobutamine and weaned the epi. This baby was very tachycardic, so we weaned down the epinephrine as the baby allowed. We allowed the right to left ductal flow by weaning our INO, which on arrival was at 20, and we were able to wean that down. We also attempted to wean FiO2 and accepted lower saturation goals of 88 to 83 on this patient. For normal blood pressure or to try to regain normal blood pressure, we started vasopressin, weaned the PGE, which, as you could see, our PDA was pretty big, and PGE also contributes to systemic hypotension, and we limited the use of sedative medications and muscle relaxants. In our HIE protocol or encephalopathy protocol, we do still utilize morphine, but we were able to incorporate this dexmedetomidine in this patient and limited the use of morphine. After our recommendations, by the time of the second TNE evaluation, the baby still required high vent settings, but we were able to wean INO down to 5. Our blood pressure had improved. Our lactic acid had come down nicely. Our pH was correcting, and the baby had no seizures. When the baby continued to be hypotensive, the team we usually use AEEGs, but they ordered a formal echo, and this baby was on continuous EEG. There was no subclinical seizure activity or clinical seizures. So also at the beginning, there was no NIRS available for this patient, but at the time of the second assessment, we had NIRS on, and they were pretty much equal, the cerebral and the renal. We do cerebral and renal, and they were both at 95. So on our second TNE, we found the LV function had normalized, RV function was preserved. So we continued weaning INO and FiO2. We were now approaching rewarming, since if you remember, we were consulted a few hours into the cooling process. So as we approached rewarming, we weaned inotropes, we weaned the vasopressin, we weaned the hydrocortisone, and we attempted to continue weaning INO and FiO2. Unfortunately, the baby still did have increased pulmonary vascular resistance, did need that INO. So we stayed on INO 5, and that was titrated up to, I think about back to 15 after rewarming, but our blood pressure normalized, our lactate acidosis and metabolic acidosis continued to improve, and our NIRS were both in the high 80s. So moving on to baby B, we're going to shift our attention to baby B and see what this baby has in store for us. So when you look at these two apical 4-chamber views, where you can see the right ventricle, right atrium, left atrium, left ventricle. You can already see there's a little bit of a difference. Besides the squeeze that is not so great in baby A, you can see that in baby B, the ventricles look a little thick, and this baby indeed did have hypertrophic cardiomyopathy. The Z-score for the LV free wall was 4. The Z-score for the RV free wall was also 4, and for the interventricular septum, the Z-score was 6. So not only did this baby have HIE, the cardiopulmonary issues that come with that, he also had hypertrophic cardiomyopathy, which made for a very challenging and interesting case. So this baby's initial cardiology echo was significant for biventricular hypertrophy with biventricular dysfunction, large PDA. This will make a point on the large PDA a little later, with a bidirectional shunt, systemic level pulmonary hypertension. So at that time, the primary team had initiated INO, dobutamine, and vasopressin, and the infant initially had shown improvement, but 12 hours after the therapies had been started, there was an acute decompensation, which prompted the TN evaluation. And at the time of our evaluation, again, the baby had no seizures. There was no NIRS available at the time. Lactic acidosis, hypotension, also still requiring pretty high FiO2 and moderate ventilator settings. On this baby's evaluation by TN echo, the RV had moderate dysfunction, as you can see here. The TAPSE was 6, which is 2 standard deviations below the mean for a term baby, as was the RVFAC of 20%, which is low. Cutoff for normal for this is around 35-ish. And LV function was preserved with an ejection fraction of 66. And now the LVO, in cooling babies, sometimes the LVO is on the low side, and the ejection fraction is usually preserved. The primary pressures were still pretty high in this patient with a systolic eccentricity index of 2. And looking at that PDA, remember I said on that cardiology echo, this baby had a large PDA that was bidirectional. Now on our evaluation, that after that acute episode, the baby now has a restrictive PDA with right to left flow and a PFO that was mostly left to right. And I will show you this little PDA right here, which is very restrictive and mostly right to left. So contrary to baby A, the hypoxemia in this patient is a result of severe pulmonary hypertension with moderate RV dysfunction and a restrictive ductus. We still did appreciate that significant biventricular hypertrophy, which is consistent with the previous echo, and the LV appeared to be underfilled secondary to decreased pulmonary blood flow. And the right to left shunt in this baby is a result of increased pulmonary vascular resistance in the setting of acute pulmonary hypertension. As Pearl went over, we know that the neonate myocardium does not adapt well to increased afterload, especially the RV. And the RV has very unique properties. In utero, it is the dominant ventricle. And then during transition, that changes with redistribution of postnatal blood flow. And that leads to increased metabolic demands on the RV. And it does not respond well to hypoxia and acidosis. It becomes dependent on preload, and it also depends primarily on longitudinal fibers that do not adapt well to increase in afterload. So when that PDA started becoming restrictive, the RV afterload increased, and we found RV dysfunction in this baby. And now this baby falls into this category with RV dysfunction, pulmonary hypertension. And the goal of management in this patient is to support the RV systolic function, reduce RV preload while maintaining adequate RV preload, in addition to having a hypertrophic cardiomyopathy. So again, if this baby was not receiving any therapies, the first line would have been dobutamine, INO, and then second line PGE if restrictive doctors, and we'll go over what we did for this patient. So to achieve and improve RV contractility on this patient, of course, we continued to correct the metabolic acidosis. We continued the dobutamine. We added PGE to maintain ductal patency, and also for its added effects of pulmonary vasodilation, we continued INO and optimized vasopressin that was already present. So we went to high dose vasopressin. We usually titrate to effects, so we ended up requiring high dose vasopressin. And in this patient, we utilized dexmedetomidine, ended up on a pretty generous dose of dexmedetomidine. Now, in both patients, the question of milrinone came up. And we did not recommend the use of milrinone because, as we know, there is a study that has shown that use of milrinone in the setting of HIE in patients undergoing therapeutic hypothermia causes profound diastolic hypotension. So we refrained from using milrinone because both our patients were hypotensive and baby B also had hypertrophic cardiomyopathy. So these babies were not, their physiology was not favorable to using milrinone. So on second TNE, the ventilator settings have improved. Our baby had no seizures. This baby had NERS at this point, and the cerebral and renal were both in the 80s. We had given this baby a dose of hydrocortisone. In hypertrophic cardiomyopathy, we try not to do that unless we absolutely have to. So we gave this baby one dose. Our ECMO team was involved. We were very close to going on ECMO, but with teamwork and collaboration, we worked together, and the baby was able to respond quite nicely. The blood pressure went up, metabolic and lactic acidosis decreased. Baby did end up receiving one dose of surfactant between the two echoes, which helped, and we're able to wean that dobutamine down to 5 and vasopressin to off. Ooh, sorry. And then the follow-up evaluation revealed a now normal RV function with a TAPSE of 10, RVFAC of 35. Our LV function is preserved, and that LV hypertrophy is still there. And our PDA is now large, not restrictive, with bidirectional flow. If I can play this for you, you can see remember how it was a little squiggle, and now it's this big open PDA, and which was now bidirectional and not right to left, and PFO, which was mostly left to right. So we are now approaching rewarming again. We were able to wean off the dobutamine, but we elected to stay on PGE. This baby had quite high pulmonary pressure, so we elected to stay. We attempted to wean FiO2, but that was not entirely successful. So the reason to wean off our pressors, continue to assess by echo, is to show that the goals of your therapy have worked. You have normalized ventricular function, so you can wean off, because as we just heard from Pearl, as we start rewarming, the systemic vasodilation will occur that will decrease SVR. We'll have increased contractility, increased heart rate, and these babies tend to have an exaggerated response to inotropes. So that's part of the reason why we continue to fall and came off our inotropes pretty quickly. After rewarming on our third, I would say this not really third, it was probably the 5th scan, the respiratory condition is improving. We're able to wean our FiO2 a little bit, but our blood pressures remain stable. Lactic acidosis, metabolic acidosis is also improving. This baby is hypertrophic cardiomyopathy. So there was always that aspect lingering in the back of our minds. And without fail, as the cooling effect wore off and the baby became warmer, more tachycardic, hypertrophic cardiomyopathy now became predominant physiology. Our RV function was preserved. Our LV function was borderline, but now we have mid-cavity flow acceleration. And now baby also has quantifiable TR, and our PDA remained large. And we had to readjust our goals for management by improving intravascular volume. We weaned off PGE since we didn't really need that at this time. Based on serial echoes, we continued the INO and continued FIO, and we weaned clinically as was tolerated. So as you can see from these two cases, understanding the underlying cardiovascular physiology, the effects of cooling, integration of T and echo, and the effects of all the medications that we give is quite important and could lead to improved precision in care of patients with HIE. So I don't want to leave you hanging. I'm happy to report that baby A, after rewarming, transitioned nicely. Ended up developing seizures after she was rewarmed, but extubated, went home on full feeds, and is thriving at home. And baby B is still with us. This baby was just from a couple of weeks ago. So he's still here. He's extubated room air and just working on feeding and other issues. Thank you. We will take questions now.
Thank you very much, Pearl and Marjorie, for this excellent talk and the interesting cases. Very well done. We'll just open the floor for questions. If you please type it in the Q&A box. So while waiting for some question, I'm going to ask some question to the panelists. So we'll start with Dr. Levy. So Phil, from the talk, you could see the role of TNE is quite essential. And I just wonder, what are your thoughts about routine hemodynamic assessments for HIE babies? I know there is no consensus at the moment for routine scanning, but what do you think about that?
Yeah, it's an excellent question. You know, my default, because we're on a NHRC kind of webinar, is to say every baby who has HIE and undergoing therapeutic hypothermia should get a baseline echocardiogram. And I think in many centers that's becoming more of a reality. I think in some centers that don't have those resources, it's more challenging. I think 5-10 years ago, it was you got an echo if there were blood pressure or heart rate changes. But I think as we've learned over the years from webinars just like this, those are late findings. What I would advocate for is a baby who's getting cooled. If you obviously are in a center that can do T&E echo, then early T&E echo, initially to rule out congenital heart disease, to look at the coronaries. Those are all important features of the puzzle. But if you are not in a center with T&E echo, then making it some type of protocol where you can get an echo within 24 hours, because I think the echo still can help you not only delineate function, identify, the perturbations to the LV and the RV and also pulmonary hypertension. But, this case that Pearl and Marjorie showed is really fascinating. If you look in the literature and look up cardiomyopathy, you really see dilated cardiomyopathy with HIE. You don't really see hypertrophic cardiomyopathy with HIE. So if you just were under the assumption that this baby had HIE and if had dilated cardiomyopathy, then your management strategy would have been totally different. And I think this just highlights the role that even if you got one echocardiogram, obviously this baby had many reasons to get echocardiograms, but standard run-of-the-mill echocardiograms where you were able to identify that it was hypertrophic, then that would guide your cardiotropic medication usage. So the long story short is I think if you work in a center where you can have T&E echo, then it should be part of your standard protocol. There's no question about that from Reagan's work. If you work in a center where you don't have that, then I would work closely with cardiology or whoever you're getting your images to at least get a baseline echocardiogram and use that information to guide the management strategies. And I'll just highlight the last point that Pearl really nicely highlighted in Marjorie is that the role of the PDA is also extremely interesting. I think keeping the PDA is open is really optimal. I think there are times where people will just try and close the PDA, but never try and close the PDA while baby's being cooled. And there's another indication for why echocardiogram is valuable. So great question to open the discussion.
Thanks, Phil. And I just wanted also to highlight that Marjorie and Pearl mentioned in their talk, they referred to the landmark paper that was published recently in the Clinics and Perinatology. Really a great piece of work and highly recommended read that was done by Regan and the co-authors as well. To the, very thoughtful discussion about the different phenotypes, how you manage each one, and what you do when they overlap. And that's why you need actually serial echoes, because things can change quite quickly. So thank you, Phil, for that. My other question to Dr. Mohammad and Dr. Wintermark about the use of NIRS in the monitoring of HIE babies. Do you use that routinely? Do you suggest that we should start using that routinely?
Khorshid, do you want to go first, or?
Ladies first, go ahead.
So I think, as Phil mentioned, if you have everything, then you can use everything. Obviously, I think there is a few things. NIRS is still an indirect measure of your cerebral blood flow. We actually measure by MRI the blood flow and then show that it was not always correlated to NIRS. So that's important to remember, that indirect measure. We also showed that during the first 24 hours of life, it can, determine the one that will develop brain injury. And so this is definitively a tool that is useful. In our unit, it's still research, they all get it, but it's not used on a clinical basis. And I think I had a question for the presenter, because I truly enjoyed the presentation, but I like the brain before the heart, I'm sorry. So we wanted to know what's happening in the brain of these two babies. What kind of injury did you guys see?
So actually, baby A, the one with LV dysfunction, had a normal MRI, which was very fascinating. And then baby B did not have any signs of HIE, but there were other findings that would not have been a result of HIE in his MRI. I think he ended up being very unstable to go to the MRI. And then our MRI vent was not working. So his MRI was way later. And he now had new changes of hydrocephalus, but that had nothing to do with the HIE. He had early ultrasounds, which had not shown hydrocephalus or anything else that you can tell on a head ultrasound.
And did he have bleeding in his brain or ventricle?
No, he did not. He did not have intraventricular bleeding or intracranial bleeding. Just very fascinating. Could have been from the fact that he's an IDM, but nothing to do with the HIE, which was fascinating.
Yeah, I would. Great presentation. I really enjoyed the physiology and the choice of inotropes based on the T&E findings. It's, as everybody said, it's fascinating. The role of NIRS, I would agree with Pia, that's still in prognostication. For me, we use it for all HIE babies that undergoes cooling in our center, but we don't direct our management based on the NIRS findings. We use it more to understand the pathophysiology and the stage of the disease. As you know, we have high NIRS, bad EEG, and we add the Doppler as well. So you see that your RI is low as well, and the baby's clinically bad. You know that the prognostication probably won't be good. On the other hand, when NIRS goes down, and at the same time your EEG is improving and your resistive index also is improving, you know that this brain is recovering. The one thing I'll add for NIRS, I still believe that NIRS' best utility is in brain autoregulation integrity, and that is the coherence between the NIRS findings and the blood pressure finding to know if the cerebral autoregulation is compromised or it's intact. The last thing I would say about the PPHN and HIE, in a way, PPHN could be protective because then by the time we get HIE, we get them during the reperfusion phase, and having little less perfusion could be good. It's more complex than the simplified way I'm presenting it, but it's when I get an HIE kiddo, the first question I ask whether the baby has PPHN or not, because that would be a nightmare. A combination of PPHN and HIE is really a nightmare. The question I have for you, if you don't mind, what day of life was the MRI done for both babies? Do you know?
So the baby A was day 5, and baby B, I think it was
way late.
Way later, 14 days or something like that. It was after the 2-week mark for sure for baby B.
Those are two perfect windows because you avoided the pseudo normalization window, which is great for both of them. You want to avoid day 6, 7, kind of 8. Thanks, great presentation.
Thank you.
Okay, I've got some questions from the audience about the if you have a baby on 100% oxygen, do you usually use muscle relaxation, which obviously can have impact on the systemic vascular resistance along with the sedation, or you just use the other sedation that you use just to try to avoid the side effects? So or Marjorie?
So I think this question is a little bit difficult to answer. I think if you already have patients that are well sedated, and even if some of them is already on phenobarbital and they're not really moving that much anyway on their own, the use of muscle relaxant needs to be judicious as well, because it can cause further systemic hypotension in patient with HIE. And if the primary team would like to do a trial of the curonium or muscle relaxant, we typically would recommend using intermittent dose instead of doing like the continuous infusion. In our 2 cases, though, baby A actually did not require any muscle relaxant because the baby was well sedated and was not agitated, and we were able to manage without having to use muscle relaxant. The baby B did receive 1 intermittent dose of the curonium, and the systemic blood pressure did decline dramatically. So then the primary team disagreed with us in like not continuing the continuous infusion. So I think it depends on the scenario. If you already have a baby that is already well sedated, blood pressure is already low, maybe holding off on using the muscle relaxant at that time might be a better strategy. Or if you really want to try using intermittent dose instead of using continuous infusion.
Yeah, thanks, Beryl. That makes sense. And question for Marjorie about the fluid management, particularly if you aim to restrict fluids. And if you have a phenotype like hypertrophic cardiomyopathy that you actually want to liberalize the fluid a little bit, how do you find that balance?
So this is another very difficult question. I feel like that goes to show how complex the HIE patients are, because you typically will not have pure HIE baby. You will have HIE baby with meconium stain, amniotic fluid, septic shock, infant of diabetic mother. That's why they get into like problems with being born initially, because they're so large. So sometimes you have hypertrophic cardiomyopathy as well. Although usually what we will do for babies undergoing cooling is to restrict their fluid so that we are not overloading them. I think finding that balance between making sure the baby tank is full, because regardless of anything, you need intravascular volume to be euvolemic or adequate enough in order for you to have adequate blood flow circulating to the body. So what our baby B actually had hypertrophic cardiomyopathy, HIE, and septic shock at the same time. So it became really important for us to do serial follow-up pretty frequently, both like with clinical monitoring and with echocardiography after we provide fluid resuscitation for the baby, just to make sure that we actually had reached the point that the baby intravascular volume is adequate and we are not overdoing it. So it was a very close monitoring and a close balance of the clinical team actually having to be at bedside and look at the different parameters of the baby, frequent chest x-ray, frequent blood gas, and pretty frequent like T and echo follow-up. So I think it will be a difficult case to answer in like a short answer.
Yeah, thanks, Per.
And I think it was a nice illustration to see the follow-up echo, because often when you ask the cardiologist, he come once and then you try the things, but you don't see if it works only clinically. So like, I think it's really a nice illustration of making sure that the treatment you choose is working as is supposed to work according to physiopathology, and then readjust if it's not the case. So I think that was a beautiful demonstration.
Yeah, absolutely. So there's a question about adjunctive therapies along with hypothermia. So like neuroprotective therapies that you use or recommend. I know there are lots of research going on about melatonin and erythropoietin, etc., etc. So that's a question for Khorshid. Do you recommend anything at the moment, or are these still in trial phase?
Yeah, we'll say cell therapy. Right. Yeah, there is. And actually, there are lots, as you said, none of them has proven to be effective. And Dr. Alistair Gunn put it in a nice way. He said the hypothermia is a curse and a blessing, because the way hypothermia works, it blunts the effect of the other adjunct neuroprotective agents. So that one of the reasons that they don't work, because hypothermia suppresses their effect. And so far, we haven't been able to generate an evidence-based effective adjunct therapy. What's in the pipeline, and I think it might work, is the sildenafil that Pia is working on, and I'm hoping she'll finish her study abroad, and then melatonin, especially if it's being given very early, because you want to suppress the inflammatory. And then nicely was illustrated that in the pathophysiology part of the presentation, then inflammation plays a big role in the brain injury mechanism. The second, I think it will be disruptive intervention will be the cord milking for those late premature babies and term babies who are non-vigorous. And the reason for that are two. One, it will improve our resuscitation efficacy, because we will have higher alert of those babies who are vigorous and need resuscitation. And we know that resuscitation is the key or one of the most impactful neuroprotective intervention. And that's one of the reasons why most of our HIEs are outborn. And interestingly, one of the studies we were looking at, the incidence of moderate to severe HIE, they were higher during the night shift. So it's all pointing out towards the effective resuscitation. So if we are paying attention to this non-vigorous baby and giving them cord milking, maybe we will improve our resuscitation. The other thing, they get a good dose of stem cells if you do the cord milking for those babies. And there are lots of literature now that is interested in implementing of stem cells, and some studies will come out, like the RCTs they will start at a multi-center RCT of an intranasal injection of stem cells. So those were the three promising adjunct intervention if I would put my money on. I don't know, Pia, what do you think?
I have obviously a bias, but I think, you know, it needs more research. It needs to know if you're trying to prevent like hypothermia or you're trying to repair, which in our case we are doing with the sildenafil. And then, you know, maybe each of them has a place depending what you have to do. And then maybe as you guys do with the TN echo, then the treatment for the brain should be personalized to what you have in your brain, you know, because obviously if you have no brain injury of HI, you probably don't need anything else. But if you have brain injury, then you may need something else.
Yeah, thank you. You could see some comments about also the use of surfactant in one of the cases actually, and that was probably a very good call that helped to improve the pulmonary vascular resistance and improve the ventilatory, like cardiopulmonary response. So what was the thoughts behind it, if you'd like just to give us a bit of your thought?
So this happened after the initial assessment overnight. The lung compliance changed, and the overnight team had to increase vent settings. And we were really trying, I think one of the ECMO attendings was covering the baby. And we're really trying to avoid ECMO on this patient. So since IDM looks like surfactant deficiency because of the change in lung compliance, so they gave a dose of surfactant, and that seemed to do the trick. Yeah.
That's great, thank you. And on that note, just probably a question for Pia, and I'm just conscious of time as well. For if therapeutic hypothermia is really complicated with very bad pulmonary hypertension, would you recommend stopping the therapeutic hypothermia, or some might argue just even go 1 degree higher up a little bit? What do you think?
It's a very debated question. I had a colleague in my NICU asking me that also, and they have done it. I actually, I would try everything to keep the hypothermia going, even if they go on ECMO or like that, and, you know, try to optimize, like our colleague did, you know, the cardiovascular in any way that it's possible, you know, but that's the only treatment that you have that can prevent brain injury. If you stop it in the middle, then you lose this chance, according to me. But I see a raised end. So.
One thing I would add, I asked this question to the neonatal neurocritical care special interest group, and it was like the tale of two cities. You see the Canadian centers, there is tendency they are okay with exiting from cooling if they have done everything, all kind of support, and there was very little center they will push to ECMO. As compared to the US center, they were more comfortable of putting the baby on ECMO. I don't know what's the right answer, to be honest with you. We did look at our local data, and it looks like PPHN itself is not a risk factor, independent risk factor of increasing brain injury. So my tendency is to push as far as we can before stopping an evidence-based intervention, which is therapeutic hypothermia. But obviously, each case is different. You have to tailor it to the case.
That's great. Thank you very much. We're now 5 minutes past 8. I just want to thank everyone for their participation, and for the speakers for the great presentation, and for the panelists for your thoughtful discussion. Tina, do you want to just
just one final word. I'm sorry to interrupt, but thank you. I just want to also thank you all for such a wonderful presentation and discussion. It was really, really fascinating and, you know, so educational for all of us. And I just want to also invite all of the audience to, to submit ideas for presentations that you might be interested in doing in the future. We are really interested in hearing from all the sites and learning about what everybody is doing. So that was what I wanted to say. And also to say hello to Carolina and welcome, to our group. And we'll look forward to meeting again next time.
Thank you. Thank you to our moderators and speakers. It was a wonderful presentation.
Thank you, everyone. See you next time. Okay, take care.
Thank you. Bye.
Bye.